I'll next bring up Professor Levit, who's the head of endocrinology at the Asuta Medical Center. He'll be presenting today on quantifying insulin resistance via CGM.
Dear colleagues, the insulin resistance assessment remains a challenge. Today, I would like to present to you the novel methods of insulin resistance assessment using CGM only without any laboratory testing and suitable for any type of diabetes. These are my disclosures. I am the founder of a Levicure startup company dealing with the regeneration of beta cells in type 1 diabetes, and I have no conflict of interest. This presentation is dedicated to my father, God bless his memory, Professor Joseph Levit, one of the leading endocrinologists of former Soviet Union. Hyperglycemic euglycemic amp still remains the gold standard of measuring of insulin resistance. Thank you. But frankly, can we consider this procedure physiological while the patient spends around 6 hours being crucified on the bed with the multiple injections connected to his extremities? Do we really think these patients would not oversecrete the multiple stress hormones? And needless to say, that is a very expensive procedure, demanding serious efforts from the patient and from the medical staff. Still, this is the procedure looks like. And still, this is far away from the real-life condition. So there are some other methods of insulin-resistant assessments, and the HOMA-IR or logarithm of HOMA-IR are most popular. But the problem is that these tests do not work properly when the patient is being treated with the insulin or has a significant beta cell impairment. And it is worthwhile to stress that most of our patients in our clinic has at least one of these signs. So we offer a novel alternative method of insulin resistance assessment derived from the CGM. Let me show you how it works. Hence, we present the 68-year-old patient has a suboptimal diabetes control and the high glucose variability. He suffers of so-called type 2 diabetes for the last 36 years, and he has a strong family history of diabetes. He's been treated with the sulfonylurea, SGLT2, and metformin on admission. His 7-day CGM data was analyzed with the help of our unique insulin resistance assessment method. And surprisingly, no insulin resistance was revealed. Indeed, we can see here the insulin resistance of his graph is virtually zero. So the question of the type of diabetes other than type 2 was questioned, and probably we talk about type 1 diabetes, multi diabetes, or secondary diabetes. Let me show you how we calculate the insulin resistance. This is the graph of these patients. And we use several CGM-derived parameters. One of them is the area under the curve, where the basis of the geometric figure is sensor glucose of 100 milligram per deciliter, and the upper limit of the figure is the average sensor glucose from the midnight to 6 a.m. This is the figure. And there are some other parameters, and the main parameter taken into account as well is the rate of sensor glucose change. So let's talk about our patients. After thorough evaluation, the multi-diabetes was revealed by the genomic investigation and the disclosure of the mutation of his specific gene compatible with the MADI3. So what have we done? With the help of CGM only, before any laboratory test done, a wrong diagnosis of diabetes type was suggested. Absence of insulin resistance became the key factor of clinical decision, and monogenic diabetes was confirmed. Therapy was changed. This all has a great importance in the family health and the specific patient's health, and the diabetes prevention is in his relatives. Our pilot study aims primary objectives were to create kind of continuous insulin resistance monitoring to provide clinicians with a non-expensive, scalable, practical tool for precise insulin resistance assessment. And secondary objectives were to evaluate the clinical value and clinical meaning of our novel method and to reveal its correlations with the main and core clinical parameters. So we studied 37 patients, all of them of any type of diabetes. All of them visited our clinics and were evaluated in our clinic in the first half of 2024, and in whom the diagnostic CGM was performed. Two experts performed the clinical evaluation of every case and divided them into three clinical groups: low, mild, and high insulin resistance. Parameters taken into account included patient's age, BMI, diabetes onset, the insulin dose, some treatments, specific hormonal conditions like puberty, and so on. The control group of 5 healthy persons was created as well. Then, a separate mathematical assessment of each CGM recording was performed by our engineering experts. All groups were compared statistically. Here on the table, we can clearly see the 4 groups: the control group, the low, mild, and high insulin resistance group, and here are the clinical parameters. Please pay attention at the bottom. We can see the distribution of IRU, insulin resistance units, quantified by our specific method, and the distribution of these insulin resistance units by groups is highly significant. This is the continuation of this table with some clinical and CGM parameters. Most of them were significantly different by groups. And this is reflected also on this graph. On the left panel, we can see the distribution of insulin resistance quantified by our methods, from virtually zero insulin resistance in the control group and the highest insulin resistance in a high group with this high significance. The same is true regarding the A1C distributed by the groups, and the same trend we can see in terms of average sensor glucose. When we calculated the correlations of our methods with some other 4 clinical parameters, the significant correlation was found with A1C, fasting plasma glucose, sensor glucose, and area under the curve. To conclude, this proof of concept pilot study demonstrates a strong correlation between CGM-derived insulin resistance levels and some core clinical metrics. Significant differences in CGM-derived insulin resistance parameters between clinical assessed groups were revealed. These methods' non-invasive nature, applied in real-life conditions, its scalability and relatively low cost, would revolutionize diabetes care. Further research with larger sample sizes is needed to validate these findings across the full spectrum of diabetes patients. Thank you very much for your attention.
Many thanks, and we have time for maybe one question from the audience, if we have any. If not, I might ask, we have individuals with diabetes on a variety of different therapeutics these days, GLP-1s, insulin. How do those factor into this midnight 6 a.m. assessment period?
Look, this is the great adventures of our methods of diagnostic and insulin resistance assessment, because we actually have the ability to compare insulin resistance changes through the time. And this is exactly what's happening in our clinic when we elevate the dose and we note the reduction of insulin resistance exactly in parallel with the reduction of the dose.
People with type 1 diabetes have insulin.
Great.
Without obesity.
Yes.
They really give insulin because of this.
Yeah.
For hypertension. Do you account for that in your model?
Yeah, of course. There are some people with type 1 diabetes in our model and in our study group. Especially there were kids in puberty with type 1 diabetes with the high insulin resistance and the high insulin demands. And this is a very good question. It works perfectly. Thank you.